Thank you for inviting us to the council to present on our work that we have done on assessing the level of mistreatment for newborns during and after childbirth in health facilities of Nepal. This is an prospective cohort observation study, which was nested within a large-scale randomized control trial. Can you have the next slide, please? As you all know, in the last 20 years, there have been huge improvement or at least change in terms of women coming to the health facilities for childbirth and postnatal care, and ensuring the continuity of care for women and for families to come to these facilities needs ensuring high quality care, not only in terms of provision of care, but also experience of care. So WHO have developed a framework to ensure that the quality of care is not seen only from a perspective of a health worker, but also from a perspective of a care recipient or a woman and families. So these might be in terms of effective communication between the health workers and the family, and also in terms of respect and dignity that they receive during childbirth or during postnatal period, and also in terms of emotional support during these vulnerable times when women and families are at most vulnerable time during childbirth. And also in terms of provision of care as per the standards, and also ensuring that there is a actionable information system which ensure that there is a continuous quality improvement process in the health facilities and the system, so that women and newborn get highest quality of care. However, what we have seen over the last 20 years, if you go to the next slide, is that to ensure upholding of the rights for women and children, there is a need of having a charter in place, both not only for women but also for newborns. And we would also like to congratulate and thank the council to ensuring that there is a charter in place which also not only ensures for women during childbirth but also for ensuring newborns as per the right of a child during birth and during postnatal period. As this has been done in the last year, and so we did the study. If you go to the next slide, well, we did this study to also assess whether there's a mistreatment for newborns in terms of your care that they receive during birth and during postnatal period, ensuring that they receive a consented care, as well as they receive a care as per the standards. And is there any deviation from the standards, or is there any kind of an abuse or mistreatment to them? In Nepal, if you go to the next slide, please. In Nepal, in the last 20 years, the institutional childbirth has increased dramatically from that of 8% in 2001 to almost 63% in 2016. This change in terms of institutional birth is mainly due to the prioritization that has been provided by the Ministry of Health stakeholders, as well as women and children who basically come to this health facility for childcare. So there have been a skilled birth arrangement policy been developed in 2006, ensuring that there should be a skilled provider for taking care of women and children, newborns during birth. There have been a maternal incentive scheme to provide reimbursement of transport money to women for the transport, as well as in 2018 there was a legislative bill being endorsed by the legislative parliament for having a Safe Mother and Newborn Health Right Act. If you go to the next slide. So we conducted this study to assess the prevalence and the factors associated with mistreatment of newborns in health facilities of Nepal. This study, as I mentioned, is a study nested within a large-scale trial to evaluate the quality of care to mothers and newborn during childbirth. Next slide, please. So this study was done in 4 health facilities. These are 4 large referral health facilities of Nepal. These health facilities have a health facility has a birth of almost 6,000 to 14,000 per year. with a estimated stillbirth of almost 19 per thousand birth to almost 21 per thousand birth every year. In these hospitals, we have been doing quality improvement projects since 2017, especially the scale-up of newborn resuscitation project in these facilities. There is a dedicated surveillance system to gather information on the care provided to the woman during labor and childbirth. And based on that information, we evaluate the process on implementation of the quality improvement project. Please. So this study was conducted over a period of 18 months. During this study period, we almost had 39,652 women who were admitted in these hospitals. Of those who were admitted, 36,723 women were enrolled to the study, of whom 34,125 of them delivered. For this particular study purpose, we included only babies who were healthy and were breathing spontaneously after birth. We excluded babies who were not healthy and not breathing at birth. Next slide, please. Yeah. So there were observations being done in several quality of care area, especially whether babies were being suctioned, which is not necessarily for healthy born baby or breathing babies. Also, observation being done on whether they were treated as per standards with kindness and respect. Whether baby was kept, whether baby was breastfed within 1 hour, whether cord clamping was done within after 1 minute, and whether there was a separation of newborns from the mothers or not, as part of babies not being kept skin contact, and also having a non-consented care, or was there any consent being provided by the parents for any routine care or not, and hygiene being maintained, especially maintained during the postpartum period. Also, we assessed the temperature in the labor room being adequately assessed or maintained or not, and also any preparedness for birth and for resuscitation. So based on these 9 indicators, we clumped them into one, reduced them into one indicator called mistreatment index. So if all of them, if there was any kind of a deviation from the protocol, then we call them as a mistreatment. And there is this mistreatment index is based on principal component analysis, which is done in developing a wealth index, where a principal component analysis has been done. A scoring has been generated from from -3 to +3. We basically scores each woman in terms of what level of care that they receive. So we consider this mistreatment index as one index, and basically analyze the level of prevalence of mistreatment among newborns. And I would request Mary to take this over. Yeah.
Thanks. Thank you, Ashish, and greetings, everyone. Next slide, please. So I will provide a brief overview of the main findings, and this paper was published in PLOS One last month. So if you want more details, please go to the website and look at the details of the paper. Next slide, please. So this slide shows the prevalence of mistreatment by the indicators that Ashish just laid out. And so I'll just summarize briefly. 1/5 of spontaneously breathing newborns were unnecessarily suctioned. 1/4 of newborns were roughly handled. 1/4 of newborns were born with poor hygiene. Almost half of the infants were born in a room with temperatures that were not adequately maintained. 2/3, so 2 of 3 newborns received medical intervention without consent from a parent or a guardian. 3/4 of newborns were not breastfeeding within 1 hour after birth, and very few were kept skin to skin after birth. And we observed variation in the prevalence of indicators of mistreatment by a woman's age, ethnicity, education, parity, term and preterm infant status, and sex of the newborn. And all of those figures are in the supplementary files and also included in the slides at the end. Next slide, please. So based on the first principal component analysis that Ashish described, the continuous mistreatment index between -3 and +3, the box plots of the mistreatment index show variation with background characteristics of women and newborns. The maximum variation in the index can be seen amongst infants who were born to women from advantaged ethnic groups, and infants born to women who had previous births or more. Next slide, please. And this is animated, so I'll start here. So this is a table from the paper with the results from the multivariate analysis. And just to highlight a couple key points. So first, we found more mistreatment amongst infants born to women of relatively disadvantaged ethnic groups. Click it, please. Thanks. We also found more mistreatment of infants amongst younger women. And click it again, please. And lastly, we observed mistreatment of newborns based on their sex, demonstrating that gender remains an important barrier for receiving respectful care in health facilities, even from the time of birth. Next slide, please. So kind of four main takeaways from this paper. First is to highlight that there's high prevalence of disrespectful care to newborns and their mothers following childbirth in health facilities of Nepal, and it's mostly affecting the most vulnerable and marginalized groups. So we need to see action now at all the different levels of the health system to improve respectful care, but it also requires an enabling environment to address health worker shortages, health worker knowledge and skills, as well as addressing social norms. The second main message is that we want to see the development of a standard set of indicators to assess mistreatment of newborns and measure respectful newborn care will be really, really critical moving it forward. So since we conducted this study, additional studies, which Emma also presented, have been published, but the data are not always comparable due to the different methods or indicators selected. So having comparable indicators or even a priority set of indicators will be necessary moving forward. The fourth point is that more research will be needed to understand the underlying causes of mistreatment of newborns during and after childbirth. So this will require implementation studies to identify effective interventions to reduce mistreatment of newborns at birth in these different contexts. And then finally, respectful maternity care requires an integrated agenda, which we've seen really this group being leaders in that space to consider both the maternal and newborn health aspects. So future studies that explore RMC for women or newborns should really include both mother-baby dyad and measure outcomes for both, including care for women after a perinatal death and the needs of the entire family and community. Since this study was a secondary analysis of previously collected data, we focused on the newborn care because it was really an unprecedented opportunity to collect this type of data at such a large scale and look at the mistreatment for newborns. But it had limitations because the objectives were different from what we were really wanting to look at for RMC for both mom and baby. So really future studies as they're being developed, we would encourage to look at both mom and baby. So next slide, and I'll pass back to Ashish, please.
Thank you. So I think looking on this paper and also based on the charter that we have on the respectful maternity care, I think we also need to look at it from a different prism. There are different drivers for mistreatment for women during childbirth and has already been published so well on that area. They are both drivers at health facility levels as well as at the community level. If you just click the slide, click all of them, yeah. There are different interventions that exist, but is having a respectful maternity care charter an ultimate goal, or is it an intervention for a future aspect? And what we think is that having a highest level of quality care is an intervention for ensuring that these women do not have any mental illness or mental disorder later on, and also having a newborn who thrives well later on. So if you click the next slide, to the next one. So right now what we're doing is we are doing a study to basically assess whether a respectful maternity care during childbirth and postnatal period also ensures that these women will have less depression, not only within 45 days, but within 90 days or within first year of life. Not only for women, but also for the partner, because postpartum depression is not only an issue with women, but also a depression issue with partners or husband. And at the same time, also assessing the child development, whether the quality of care has an association with the child development at different point in time. So hopefully, in next year or two, we will have more evidence on the evidence on intervention as a respectful maternity care in terms of postpartum depression as well as child development. And I think that's my last slide. There are a few other slides, I think, for the reference to the group. Yeah, thank you.